seeing in on YouTube. So once I say yes, then you start.
It's live now.
Yes, it's live. So, sir, you can start. Welcome all.
Good evening, everyone. This is the new concept that has been planned by our expert, none other than Bala Subramaniam sir, who is my predecessor and my guide. And we discussed about it, and we wanted to make it very lively. And I requested him to continue this for a long time. So he planned it for 11 episodes. 11 episodes means by this end of the year, it will be over. But we are interested in extending it and continuing it further, and we will decide it with the incoming chairperson and all others. This is a trial what we are doing. This should become most informative about the ID. That means only infectious diseases. We will not deal any other thing. If at all we deal other thing in that aspect, we will discuss only infection in that condition. With this understanding, we have trying to start this program, and I say that I wish Chetan Balasubramaniam sir a grand success in continuing this and making it a very good program of PIDA. Thank you. Welcome one and all.
You're not audible.
You are mute.
Sorry. Thank you, Dr. Darur sir. Thanks for that welcome note. And now, before Basavaraj sir joins, I think I would request our Central IIP President-elect, Dr. Vasant Khaladkar, our ID man, to say a few words.
Good evening, all. Respected Dr. Dararu, Dr. Chetan, Treasurer, and all ID members, which is ID chapter, you all know, is always by my heart. And I started my, I think, pediatric career with joining ID chapter before my presidentship in Nagpur. So really, my different affection for that. And I saw the vibrant, this is a really vibrant chapter, I know. And with person like Dr. Bala Subramaniam, Dr. Ajusha, Dr. Abhay or Jaideep, our Kundu, and all these people are there. I think this remain a vibrant chapter, definitely. Of course, Dr. Bastavaraja is also having a great affection for the chapter along with the intensive care chapter. I know. And that's why this is always we are on the top. ID chapter is always top, whether it's a award, whether it's and there's a opening of a grand round, that is 11 session series. Really a great idea. Nobody can think than Dr. Bala. I mean, Bala is there. बात क्या करनी है, क्या सोचना है? There will be a grand success. I know about the capacity of ID chapter. So I wish all the best for this grand opening of this series. Thank you.
Sir, welcome to Dr. Basavaraj sir, Chair.
Thank you so much, Dr. Vasant. That was for nice words. And now we are happy to see a vibrant face, a very busy guy, but still he has just made it to be here. Welcome our IIP President, Dr. G.V. Basavaraja sir. And Dr. Basavaraja, yes, you know that we are going to start this webinar series, monthly webinar. Last Thursday of every month, we'll be having this Super 11. And as just now we discussed that Bala sir coined this term, Super 11, that 11 episodes of different aspects or different parts, topics of ID will be covered over a period of next 11 months which we have. So welcome, Dr. Basavaraja, and we would like to have you a few words of blessing from you, Dr.
Yeah,
Basavaraja.
thank you very much, Dynamic Secretary of Infectious Disease Chapter, Dr. Chetan Trivedi, our honorable teachers of teacher, who is always creative and innovative, none other than Dr. S. Balasubramaniam sir, and our chairperson of ID chapter, who has been very dynamic, and none other than Dr. Daru Ranganath. I am in your Hyderabad city only.
Yes,
And
welcome.
yeah. And of course, the stalwarts in the infectious disease, our Jain Joshi ji, Manish, and Dr. I can recognize the presence of our honorable visionary president of Indian Academy of Pediatrics 2020, Dr. Bakul Jayant Parikh sir, and all of them. And our president-elect has rightly said, infectious disease is our core subspecialty chapter in our day-to-day clinical practice. In fact, I am closely associated infectious disease for more than almost to the decade, 2 decades. And the infectious disease is one of the chapters which has been doing a great work in the academics with the stalwart like S. Balasubramaniam sir, Dr. Vijay Avle, Dr. Professor Shivanand, and many of them are really did a great job from Dr. Narayana and all. And the things which has been carried forward by the present team, Rangnath Darur and Dr. Chetan Trivedi and our incoming chairperson of infectious disease chapter, Dr. Bhaskar Shanai, with the guidance and always very supportive of it, none other than Dr. our SBS sir. Things which is going to come for the next 11 months is going to be the super hit. Reason being is, whatever Dr. SBS sir takes, he will do it with the perfection, do it with what really the pediatrician needs, what really our ID experts request. I always say Dr. SBS sir is a DM in all, not only in infectious disease, emergency medicine, critical care, you take anything. Sir is a mastery of all. So it is always pleasure to listening to his concepts and all. So Grand Rounds was one of the things. Legends and Legacy is one of the things what I discussed when I was IIP Bangalore president. So that just we are giving a different name to it, but ultimately these are all the creative of our SBS sir. And the coming days, so infectious disease is going to be benefited with the guidance and presence of Dr. SBS sir. So looking forward to the successful 11th series, not only 11 months, it is going to be the more than 11 years. That is rightly been put. So wish you all the best, Rangnath Daru sir. I know your zeal and enthusiasm to work for the organization unmatchable, and we have seen over a year. So wish you all the best, Dr. Rangnath Daru sir.
Thank you, sir. Thank you.
Thank you so much, Dr. Basavaraja, for those nice words. And now we have three past presidents of IIB. So first, I would request Dr. Raju Shah to say a few words.
He left, I think.
Yeah, he's there.
He's there. He's there. He's there. Very much there.
Yeah. Good evening, everybody. I'm so happy that I'm witnessing a marathon which is going to be, inaugurated by his first session by Dr. Bala. We all know that in last few years, as an ID chapter person, as a chairperson, as well as an expert in ID, he has, chaired many sessions on ID, and he has sort of created a new enthusiasm in pediatricians to learn certain basics of the ID, and which is going to help a lot in their day-to-day practice. I am sure with this Super 11, which he has planned, there will be so many new ideas that will be coming to the pediatricians and their practice, and in a way, the society will also benefit. So my best wishes to the ID chapter, and the main brain behind it, Dr. Bala. Thank you very much for inviting me for this inaugural session. Thank you.
Thank you so much, sir. Dr. Vijay Evle, I think your inputs will be required even afterwards also.
I can only say that I'm looking forward to this super duper, program which has been planned by none other than Dr. Bala under the chairmanship and secretaryship of superhero Dr. Ranganath Daruru and Chetan Trivedi. And I'm sure, this is going to be very useful to all the practicing pediatricians and even the teaching faculty across the country with teacher of teachers like Dr. Bala. And we have, what more could we have asked for than having Dr. Kabila Rodriguez as one of the, faculty for the opening session of this thing. So I look forward to a great session. Wish you all the best. Without wasting much time, I would hand it over back to Chetan so that we can have a fruitful discussion.
Sir,
thank you.
Thank you so much, sir. And last but not the least is Dr. Bakujan Parekh, who, made us sit in the front of this laptop. Bakul bhai.
Yeah, so thank you, Chetan. So my dear friend, Dr. Ranganath Daruru and Dr. Chetan Trivedi, I think you have started your innings in the beginning of the year with a master blaster, master of all, jack of none, Dr. Bala Subramaniam. And of course, with a colleague like Dr. Kabila Rodriguez in the first session, I'm going to witness a great successful beginning to this Super 11 series. So all the best to everybody. And thank you very much for inviting me here.
Thank you so much. And now I think I'll be just handing over the stage to Dr. Bala, sir. He's going to run the show. So we have given responsibility to open the innings. He'll introduce all these faculties and he will say a few words as scientific convener and what is his idea about this.
Yeah.
Dr. Bala, sir.
Please allow me to share the screen, Dr. Chetan.
Sir, you can share the screen.
Okay. Is my screen visible?
Yes, sir.
Yes. Yes.
Yeah. Okay. Audio is okay? Yeah. Okay.
Yes, sir.
Okay. Thank you very much. At the outset, I'm grateful to Dr. Daru Ranganath, the chairperson of the ID chapter, for entrusting me the responsibility of opening the innings for this Super 11 sessions. But I'm a bit nervous for two reasons. One, the topic was given to me by Chetan and Dr. Daru Ranganath only about 5 days back. And I had very little time. I sat down. Of course, I was not very much worried from one angle because the quality of the experts we are having today is fantastic. But at the same time, I was a bit worried because I didn't have much time to think about and plan how to go about doing the session. I tried my best to make it as clinical and as interesting as possible. And I thank all those who have complimented our PIDA team for the sessions. With so much of talent available in our Pediatric Infectious Disease Academy, starting from our present chairperson, Vasan, Bhaskar, Chetan, seniors like Dr. Raju Shah, Kundu, of course, Vijay Evale, Tanu, so many. There is no reason why we should not successfully conduct such programs starting from this month. So we have 11 months, and I'm sure we will have 10 more sessions with probably more talented experts doing the sessions. With this introduction, the focus for today's session would be case scenarios with dilemmas for the clinician in laboratory tests related to pediatric infectious diseases. And we are going to talk about some pitfalls in performance, storage, transport, interpretation of a few tests related to PID. And we will have clinicians' viewpoints. We have two clinicians, one young and one very, very experienced. The young one is none other than Dr. Shalini, who's a fellow of our own chapter, who's a consultant pediatric infectious disease specialist at Bangalore. Welcome, Dr. Shalini. She will be accompanied by another distinguished pediatrician, a senior one. I don't think I need to introduce him. He's none other than Dr. Yagnesh Popat, the former chairperson of the PIDA. With his wisdom combined with Dr. Shalini's training in ID, will clear all the doubts from the viewpoint of the clinicians. And when it comes to microbiology, we have somebody who I would say is like a Supreme Court judge for today's panel. Is none other than Dr. Camila, the microbiologist of renown from Mumbai. We all know her. Pediatricians have got a lot of affinity for Dr. Camila's work in pediatric, because she has done a lot of good original work in tuberculosis and fungal infections, etc. And she will probably be the Supreme Court authority during the discussions today. Welcome, Dr. Camila. And she'll be accompanied by somebody distinguished and coming up very fast in the microbiology map. That is Dr. Sulochana Putlibai. She is the lab director and chief microbiologist of Kanchi Kamakodi Children's Hospital. In the last 10 years, she's done a lot of original work related to pneumococcal disease, typhoid, etc. And these two microbiologists will give expert verdict towards in the end of the discussions on controversial areas. Of course, there will be some take-home messages from these case scenarios. With this brief introduction, let me start discussing a case to begin with. This is an infant with fever, 1 year old, 4 days of fever. Somebody has done urine routine and culture. And somebody has started on amoxiclav, 50 mg per kg, on day 2 of fever. The child is better, afebrile, and they come to you on day 4 with a report like this. Urine routine, albumin 1+, nitrite positive, leukocyte esterase positive, pus cells 30 per high power field, and culture report E. coli 10 to the power of 4. The lab report says it's sensitive only to meropenem, resistant, pan-resistant to almost all the known antibiotics. Now, this is not an infrequent incident, I would say. I come across like this at least once in a year or once in 6 months. And I'm sure many in the periphery would come across such scenarios. To start with Dr. Yagnesh. Dr. Yagnesh, you have your patient in front of you. Child is better, but this is the report which is there. As a senior pediatrician, how will you approach this problem? What will you do? I mean, since this is going to be stressed on labs, please start from clinical and then proceed to labs. Over to Dr. Yagnesh.
Thank you, sir, for the wonderful introduction of the case in the beginning of the series. As per the diagnosis in this case is concerned, it is UTI, that is without doubt, because nitrate test is positive, leukocyte esterase is positive, pus cells are there. Now, second aspect is the culture. E. coli 10:4 positive. Whether this should be considered as positive or not, that depends upon the how the urine has been collected. So depending upon that, we can interpret whether this is a contamination or whether it is a real culprit. Then the second part of the culture is the sensitivity only to the meropenem. If the child is afebrile, only on amoxiclav, I would not like to change the antibiotic. We'll continue with the same antibiotic, because in vitro and in vivo sensitivity definitely differs, as there are, it is likely that the amoxicillin have a better concentration in the urinary bladders and that is why it has cleared the urine. But in vitro, that was not positive, or maybe it was resistant. So I would continue with the same antibiotic in this case, neglecting the culture report of sensitivity, especially.
That's a very bold statement in front of two senior microbiologists saying that you would you might how dare
I
you.
do not, sir, I do not say that I do not believe in report. I
No, it's
believe in
okay.
report, but
In a
I
lighter
am
way.
interpreting it in this
No,
way.
in a lighter way, I said. Now, this case actually makes me think about several problems in practice. I mean, one of the most difficult things to collect is the so-called midstream
Midstream.
urine. Midstream urine. You must be a good wicketkeeper like Dhoni to collect a midstream urine, particularly in infant. There are so many difficulties, and I'm going to ask you and Shalini, what do you do? Suppose this same child, 1-year-old child, you had suspected urine infection. How would you have collected urine in this child? What instructions would you have given to the parents before you even go to interpret complicated lab reports? Dr. Shalini.
Yes, sir. Thank you very much for the question. Thank you for including me here. Like you said, one of the most challenging things is urine collection, especially in younger children. It's easier said than done. So it's very easy for us to say, please collect a urine sample, give it in the lab and get back with the reports. And of course, parents face all the logistic problems. The commonest thing that we do routinely in practice is a clean catch midstream sample. So the advice I give parents would be to wash the genital area with simple soap and water. Wait for a while, take the child and encourage him to urinate. Discard the first part of the stream, collect the middle part of the stream directly into the sterile container. Do not touch any part of the container other than the outside. Cap it immediately and hand it over to the lab. Now, if this is done, this has quite a low rate of contamination. But of course, this may not always be possible. The gold standard for collecting the urine sample is a suprapubic aspirate, which we tend to use in much smaller infants, hospitalized infants. Otherwise, intermittent catheterization in and out also is a very good way of collecting a urine for interpretation for UTI.
Now, there are several methods of collection of urine sample. You see, you can use a urine bag. You can get the so-called clean catch. There is what is called, we'll talk about it, voiding stimulation, catheterization, suprapubic. I mean, the two extremes are almost out in the sense bag collection is not sensible. Suprapubic nowadays is not recommended. It's no more done. In fact, I have not done a suprapubic aspirate in the last 15 years or so. Catheterization, parents may sometimes refuse. Clean catch, as I said, you require Dhoni. Now, which one do you prefer, Dr. Yagnesh and Shalini?
Sir, as far as the routine day-to-day practice is concerned, we prefer the clean catch along with the voiding stimulation whenever required. So that will be my first choice. And if that is not possible, only then we'll go for catheterization when we are strongly suspecting UTI.
Okay. There's something which is very old, but which is not often followed. It's called quick wee technique. I'm surprised why many pediatricians don't follow it. It's so simple to follow. You don't have to catheterize at all. It's a very simple technique. It's been validated by several studies, including this one in the British Medical Journal way back in 2017. This consists of actually taking a sterile gauze soaked in cold fluid, saline or water, and just stimulate without putting pressure on the suprapubic area. I believe the success rate is around 75 to 80%. I think pediatricians should be encouraged to do this. But once it is not possible to do that, I think the best thing is to only catheterize, suprapubic is out, and urine bag. Suppose somebody comes with a report with a urine bag culture. What do you do, Dr. Shalini?
So the urine bag sample has a very high rate of contamination. So it has an excellent negative predictive value. So if that is negative, then I would say the likelihood of a UTI is very low. But if it's positive, I would take it with a pinch of salt. I would ask, especially if there is a mixed growth or an organism or a sensitivity pattern that does not explain and correlate clinically, I would ask for a repeat sample, either catheterized or ideally a catheterized sample.
I think that's a very sensible point. I mean, and I have had occasions, some VIP parents, they have refused catheterization, and the only way they could collect sample was only urine bag. If the urine bag sample does not grow anything, I mean, it has got good predictive value of ruling out a urinary infection. But if it is growing something, I mean, it has got poor predictive value of positivity. The only thing is, you should, if you have collected a bag specimen, presumptive antibiotic treatment should be avoided. Having talked about the difficulties in collecting samples, I'm going to ask our microbiology experts. There's a lot of discussion on the colony counts. In fact, if you go through the literature, the so-called colony count in pediatrics has not been very well validated at all. And as seen in the slide, which I'm going to show, this is in one paper, there are 6 different colony counts from different agencies, from CDC, Canada, AAP, etc. I'm going to ask Dr. Sulochana and Dr. Camila, what do you think should be the correct colony count we should follow? Because most of us get only a clean catch specimen or a catheterization. What colony count should be taken as significant? Dr. Sulochana and Dr. Camila, please.
I request Dr. Camila madam to
Sulochana,
yes.
you go ahead. This is
Okay. Thanks, madam. So as Dr. SB has told, it is truly confusing with so many guidelines giving different significant colony counts. But a standard one that we follow, or I would recommend, is for a clean catch, more than 10 to the power of 5 or 1 lakh colony forming units per ml. That's the best. We have seen it correlates very well. And for the suprapubic aspiration, which is rarely done, but very certain times it is done, any growth, because it is collected in a very sterile manner, we go with any colony count is significant. And when it comes to transurethral catheterization, there are 2 schools of thought. One, the urethra will be having the normal flora, so it is good to have a significant colony count rate of 10 to the power of 4. But in our hospital, because it is a invasive sample collection, we report all the colony count. So this is what we follow. And it has been successful. We were able to identify urinary tract infection as well as completely rule out the urinary tract infection.
The clean catch 10 to the power of 4. Dr. Sulochana and Dr. Camila, will you ignore or take it as relevant?
So we take it as relevant, sir. Here.
It's symptomatic. Okay. The
Yes.
current guidelines, most guidelines have moved towards taking 10 to the power of 4 rather than 10 to the power of 5.
5.
What about the transport and storage? As microbiologists, what are your suggestions to pediatricians?
Naturally, the time to transport the sample after collection is going to be very significantly affecting the result, because the flora is going to be mixed with the urine, and urine is an excellent culture medium. So it has to be transported within 1 hour. That is, logistically, it is going to be difficult when the collection is done at the home. But if there is a delay, if it is refrigerated, it can be stored up to 24 hours, it is allowed. But currently, there is one more system that is available called as with a preservative with boric acid. It is available in the BD, which if it is collected in that, even at a room temperature, it can be kept at 48 hours, but is rarely used. But we are able to manage with the collection happening in the hospital and getting the sample within 1 month.
To Dr. Camila, in this case, everything is resistant. Meropenem only sensitive. What should a clinician do in case the same child had not responded?
Put it this way. the discordance between in vitro and in vivo is there, especially with urine samples. Now, in this case, we have this baby. I clearly know that she has a UTI. And I think since the most important point is that there has been clinical, because empiric therapy is changed only if there is clinical failure, that is presence of fever, maybe lack of clinical improvement regardless of the AST. So here, in fact, studies in pediatrics have shown that initial antibiotics may be resistant, but patients have improved in almost 50% of hospitalized cases again. So in this situation, now you have collection is a huge issue. We've been through that. E. coli is the most common pathogen. We've shown that this kid has a dipstick positive for LE and nitrite. So there's clearly UTI. If the kid does not have any risk factors for resistant pathogens that include exposure to antibiotics in the last 3 days, no antibiotic prophylaxis, no urinary tract anatomical or functional anomalies, I don't think that only meropenem can be susceptible in this case. Also, the baby has responded. And the most important point is that we microbiologists pitch our clinical breakpoint. So when we report SOR, we base this on blood concentrations. Dr. Vesh just said that antibiotic concentrations in urinary tract are often higher than in the blood. 600 times amoxicillin concentrates in the bladder. So clearly, since we report breakpoints based on the blood concentrations, here I would definitely say that the meropenem, it's not that it's wrong, it's just that the microbiologist has reported the serum breakpoints rather than the urinary breakpoints. So regrettably, there are no urinary breakpoints today. So here, this in vitro is going to be discarded.
Dr. Shalini, one final question. Suppose we come across cases of pyelonephritis where we start ceftriaxone, the report comes as ESBL, and the child is better. Do you continue the same ceftriaxone or amoxiclav, or you change to some other drug to cover ESBL routinely? What is your suggestion, Doctor?
So I would continue the ceftriaxone as long as the child has responded. It is okay to continue. In fact, even an oral switch is acceptable if the child is doing well.
It's a complicated UTI, a child with anatomical abnormality, recurrent UTI. Will you still continue ceftriaxone or change?
Dr. Bala, can I say I would change?
I would, correct. Yeah. Stable child, no risk factors, in vitro response, in vivo response is good, you don't change. Complicated problem, yes, one would always consider changing. Okay.
See, Dr. Bala, just to butt in again, the urinary breakpoints, the serum breakpoints are precisely for pyelonephritis. They're precisely built so that we don't miss a bloodstream for a serious complicated urinary tract infection of the upper urinary tract.
Okay. Let us move on to the case number 2. This is a 3-month-old, had a high fever of 104. The pediatrician rightly admits the child, does a septic workup, and then he starts on ceftriaxone. He does sends a blood culture. 48 hours, child stable, but fever is continuing. No complications, no localization yet. And the blood culture at 48 hours is flagging cons. And the microbiologist says it is sensitive only to vancomycin and linezolid. Dr. Shalini, how would you react and how would you proceed at this point of time?
So the first thing that comes to mind is this significant organism? Does this organism explain this child's sepsis? Is this
How do you know this is significant?
So some of the markers are, one would be the age of the child. In a younger child, it's more likely to be the pathogen rather than a commensal. I'd go back and ask about the method of collection, whether proper sterile techniques were used, whether there was any contamination in the collection. And most important is the time to positivity in the culture.
No, how will you retrospectively identify that there is contamination during collection?
I would just discuss with the persons collecting it, sir. But time to identification, or if more than one culture has been collected, and if they both are positive, then definitely it is a sepsis. Whereas if it is only one, then it's more likely to be a contaminant.
Okay. In fact, this is a very interesting part of an article on blood culture. In such a situation, I believe I'm sure Dr. Sulochana and Camila would agree. The decision is entirely clinical. Am I right, Madam Camila?
Perfect. Yes, sir.
See, suppose the lab gives a report, it's cons, child is still febrile, the decision cannot be made purely because of the blood culture. The only decision, the only factor which will influence the decision will be when the flagging occurred. Am I right, madam? Is there anything to do with at what stage the machine picked up the con? How does that matter?
That just indicates the load. What was the load of the...
Okay. So I believe you can ask 4 questions, four or 5 questions. One is that whether the child has symptoms and signs and also laboratory parameters consistent with sepsis. And the organism a likely pathogen, for example, cons or alpha hemolytic streptococcus, they are unlikely to be urinary pathogens. And is there an indwelling vascular catheter or other device? Have you done more than one culture? In fact, in our hospital, in the ICU, our intensivists always they do 2 blood cultures, and both are growing, then I wouldn't ignore. And is that a child? I mean, is the child one who belongs to the high risk group, which includes oncology, burns patient, very low birth weight, etc.? If all these questions are negative, then I think the culture can be disregarded. And I'm again repeating, the decision is purely clinical. Now I'm going to move into more difficult questions. Madam Camila, do you recommend one set of blood cultures or 2 sets of blood cultures? And what is the volume would you recommend the pediatricians to follow? Because there are conflicting views. Somebody says you have to draw 6 ml, 3 ml, 1 ml. Various papers are given, various volumes. I'm sure there is no uniformity. In fact, I know even in Chennai, many hospitals, each hospital follows one volume. Newborn unit has 1 volume, ICU has 1 volume, emergency room has got 1 volume. What is your recommendation, madam?
See, one thing is clear that increasing volume enhances the chances of isolation. In fact, each ml that you add to the blood culture bottle increases the isolation rate by 3%. And the second point in favor of doing many cultures or sets is that it helps, like Dr. Shalini said, distinguish clinically important isolates from contaminants. Now, just to sort of put into perspective, commensals are Propionibacterium, Bacillus diphtheroides, and what are always pathogens are Staph aureus, E. coli, Enterobacterales, Pseudo, Candida, etc. What are sometimes pathogens are VGS, that is Viridans group of strep, Enterococca, and cons if there's hardware. So now you ask me how much blood to collect and how will I inoculate my bottles. Basically, in kids, we use this formula 1% of total blood volume. So we take 85 ml per kg in newborns, 73 ml per kg in others. So that works out to approximately in a 9 kg child, it will work out to about 2 ml. In a 13 kg child, about 3 ml. A 26 kg child, 10 ml. Now I'll stop here because how are we going to inoculate the bottles? If it is less than 3 ml, only 1 bottle. The reason is that if you, it's enough to do just 1 bottle. You can't split the less than 3 ml into 2 bottles. And if you have 10 mils, you don't want to overfill the bottles because overfilling also affects the blood cultures. It doesn't allow, you can't put all 20 mils into 1 bottle because that will be worse. It doesn't work that way because that itself has its issues. So up to about 26 kg, I would take 8 to 10 ml in 1 bottle. Now, if I'm suspecting an anaerobic infection, if there's neutropenia, if there's PRM, I would also inoculate an anaerobic bottle, mainly because I feel that the anaerobes are important pathogens there. So for a kid who is more than 25 kgs, definitely I would inoculate 1 set. If the child is in the community, if it's in the ICU and sick, 2 sets. And above that is going to be 2 sets.
Okay. I came across this statement from one of the articles in Archives. Of course, as you rightly said, the higher volume yield may go up. Very high volumes may actually decrease the yield. And in newborn, 1 ml is enough. In older children, maybe up to 6 years, 3 ml is enough. Maybe you can consider taking 6 ml in older children. And that in a non-ICU setting, would you recommend that higher volume, or do you think general rule of thumb 1 to 3 ml should be enough for a practitioner doing OP practice and asking for blood culture? Please comment, please.
Dr. Bala, I would not go by years because I have a very thin little 5-year-old and I have a chubby 4-year-old. I'd go by the weight.
Go by the weight. Okay. Dr. Sulochana, what is the volume that you recommend for our hospital?
Ours, because we follow the pediatric bottles, it is up to 4 ml. It can only take the 4 ml because, as Dr. Kamila Madam told, the ratio between the blood and the broth is very critical for a good isolation. Less or more can, even adding more blood to the blood culture bottle can actually decrease the yield. So we follow up to only 4 ml per the pediatric culture bottle. And if it is an adult, we go for the higher volumes. And for neonates and younger kids, the concentration of the bacteria causing the sepsis is very high. So what we have practically seen is even a single bottle in a neonates or younger children, we are getting an excellent yield. So this is what we observe.
Incidentally, there are references which have shown that in newborn, taking 2 blood cultures does not improve the yield. In fact, I'm putting a reference here. On the other hand, in complicated cases, those who have neutropenia, those who have oncological problems, I think 2 blood cultures are definitely better than one blood culture. And for a practitioner, I think it's easy to remember 1 to 3. If it is young infant, it is 1 ml, and a slightly older child, 3 ml. Of course, above 6 years is 6 ml. I mean, that's a simple rule of thumb, because for my statement, there are not many hard references. I can only quote this article, which says that 1 to 3 ml should be good enough, and increasing the volume alone does not increase the yield. Okay. Let us move on with the...
Dr. Bala, can I just say one thing? If you consistently get cons, you have to instruct the lab to teach the pediatricians how to collect, whoever's collecting. So in our lab, we have when the contamination rate goes more than 1%, that means 1 out of 100 bottles is, say 2 out of 100 bottles is growing cons, we immediately start a training program for all the collectors. How to collect, how to clean, what disinfectant you use, and we find that really helps, because the people just sort of chalega and then don't palpate the vein, how to do it. All those instructions must be, so you have to have a reflex point by which you start your training again. So we have it at least 4 times a year. Minute our cons goes up, because you see, for pediatricians who are sensible physicians, it's fine, but the ICU people love the cons because it gives them a reason to start vancomycin. Because today almost 95% of our cons are MR. So we report resistance. So just to stop that, we have to stop the practice right from the beginning. So train the trainers who are collecting.
Very well said. Very well said. In addition to good clinical assessment of patients, while you order investigations, you must give the right specimen to the microbiologist or the pathologist. The right specimen is an uncontaminated blood culture specimen. Okay, very well said, madam. Thank you. Let us move on to a respiratory case where there are a lot more problems than in blood culture or in urine culture. This is a young infant who was admitted about 2 weeks back under my care. This infant had respiratory distress, low-grade fever, wheeze, hypoxia, and an X-ray was done. The X-ray was reported as a segmental consolidation of the upper lobe. Just above the minor fissure, there was a triangular homogeneous shadow. In addition, there is also bilateral hyperinflation. And this infant we did a blood culture counts and started on ceftriaxone. Saturation was 80, required oxygen support. And we did, because it's a severe pneumonia, we did a nasopharyngeal aspirate biofire. The report came within 4 hours, metapneumovirus positive. And the blood counts are normal. Low-grade fever was there, wheeze was there. It took about 3 days, 2 days antibiotic, the status was same. And how do you interpret this biofire report, Dr. Sulochana? As a microbiologist, once you get a report like this in a child who has what looks like a pneumonia, what do you do with this report? Do you think the question is, what are the limitations and interpretation in the interpretation of NPA biofire, which is one of the most common tests done in pneumonia today? And if the biofire test is positive, when is it likely to be positive due to a true pathogen and not a bystander? And of course, the next 2 questions are to Shalini and Dr. Yagnesh. When should pediatricians ask for an nasopharyngeal aspirate biofire? And when should we, what about the new biofire pneumonia panel in sputum or in ballot? Sorry, 4 questions, but first 2 questions to the microbiologist. Dr. Sulochana, please.
So the current biofire is actually it was a game changer, particularly for the respiratory illness. Now they are sending for biofire, and it is giving certain times in excellent results, but also certain times it confuses the physicians. In this case, the greatest limitations for the biofire is it can identify only certain set of organisms. It cannot identify beyond the limit. So what is shown here is this is the list of things it can identify, and in this, certain organisms can be a bystanders. It can be a colonizer. Like in this case, the human metapneumovirus you cannot, without a clinical correlation, you cannot say that it is the causative pathogen. But like the bacteria, like the Bordetella pertussis, if it is present, we can say it is the pathogen. So it has to be clinically correlated. What we in our hospital we have seen, it is excellent correlation with the RSV influenza. Particularly, it helped us a great deal in stopping the unnecessary antibiotics. That's where we were using the biofire for stopping the unnecessary antibiotics that they started. Once it is confirmed it is RSV, they stopped. This is the advantages and the limitations of the biofires.
I think there is a very, very interesting paper which has actually looked at the the interpretation of the biofire or the multiplex PCR positivity. As seen in this slide, RSV, if it is positive, there is a 93% chance, 0.93 is the odds, confidence intervals of the odds ratio, AF, and 93% chance that it is a true pathogen, RSV. Influenza nearly is 100%. If it is positive, it is likely to be true influenza. Metapneumovirus is close to RSV with 0.9. On the other hand, something like rhinovirus has got very, very low AF, 0.12. So that can be a bystander. Adenovirus has got only 0.44. Corona, surprisingly, if you put together, not COVID-19, all the coronavirus put together comes to around 0.68. The important point that you must remember, amongst all the organisms, in addition to, pertussis, etc., chlamydia, it's not very sensitive. Pertussis is quite sensitive, your biofire PCR. Detection of influenza, RSV, parainfluenza, or human metapneumovirus signifies that the virus is likely to be the cause for clinical disease. So not 100%, most likely. In the given case, there was low-grade fever, counts were normal, the pneumonia was like this. We discontinued the antibiotics. After about for 24, 36 hours, we sat down and we just put an assessment saying this is not likely to be bacterial pneumonia. And we followed the infant with bronchodilator. And it is one of the very important steps for antibiotic stewardship. That's what we wanted to say. Madam Camilla, what about the pneumonia panel from the ball or from the sputum? How often it is useful? And what's your comment on this? And when does a pediatrician do it?
Dr. Bala, I have a disclosure to make. I don't use the pneumonia panel at all. The reason is I like the respiratory panel or the upper respiratory panel because it has more viruses. Here, if you look at the bacteria, there's so many bacteria in this. I mean, I don't think Enterobacter, E. coli, Klebsiella aerogenes, Proteus, Serratia are real pneumonia panels and pneumonia pathogens. I don't know why they are there. And if you look at the carbapenem resistance, it really picks it up well. That is a good part of the pneumonia panel, but it's also in the BCID, the same panel of carbapenem. So where would I really want to use it? See, they try to it really, to me, why when we did an initial study, we found that it was picking up all the colonizers in the throat. And that was because they were so resistant in patients who were sick. The clinicians were tempted to cover with high-end antibiotics for a virtual non-pathogen. E. coli, that was an NDM they were wanting to treat. So for that reason, we said, no, we are not going to start this test. We will wait for culture and we will give antibiotics as per the hospital's policy. So here, I think, little caution is required. Unlike the respiratory panel, the upper respiratory panel, here I think they have something known as bins, 10 raised to 4, 10 raised to 5, 10 raised to 6. But we've not been satisfied with that so far. So I don't use the pneumonia panel. I don't know, Silochana, are you using it?
Madam, we especially use it only in the ICU for certain specific cases, for cases which was transferred from outside hospital. We know that it is a high, it is a VAP. So we have a very specific use, and that too specifically they use a pneumonia 2 panel where it can identify the Acinetobacter. We have seen a case 2 or 3 months where a child was transferred from an outside hospital with a ventilator associated pneumonia. So they sent it for biofire. Also, they sent it for the culture. We grew Acinetobacter, which was only sensitive to colistin. But fortunately, they were able to pick up the Acinetobacter as well as the resistance pattern very early, within 2 to 3 hours from the biofire. So they started the antibiotics and they could save the child. Very limited. Only such specific cases where they feel that they can identify the pathogen as well as the resistance pattern. It was not a regular one. It was not.
If you have responsible clinicians who understand this, yes, I would recommend. But currently, we are not using it.
Not a standard practice.
Dr. Yagnesh and Dr. Shalini, as pediatricians and the ID experts, when do you ask for these 2 panels? When have you asked for these panels?
So one of the common times to use it is when we are admitting children during outbreaks or epidemics for cohorting. It becomes important to cohort them into, single wards and things like that. The other time is in a sick child, like ma'am was saying, in the ICU in a sick child when we need to do, and more importantly for antibiotic stewardship. If higher end empirical antibiotics have been started and we get a positive PCR on a virus, then it will help us to de-escalate.
Yagnesh?
It gives a result within a couple of hours. So when the time is our need, we can offer the biofire. Of course, it is a costly test, so it cannot be used for everybody. But when the question of life and death, definitely it is useful in ICU setups.
Most papers on such multiplex PCR, they suggest that these tests should be done, one, as rightly pointed out by Shalini, for epidemiological purposes when there is an outbreak. 2, for hospital infection control to cohort cases of the same virus. 3, when there is an outbreak, you want to investigate and find out what it is. 4, as a step for antibiotic stewardship, once it is COVID-19, And once it is influenza, you will not use any antibiotic. And last but not the least is to know epidemiologically what is going on in the community. In fact, last year we all remember we had a lot of adenovirus pneumonia, which which was being badly treated by all of us because of high CRP and high fever, etc. These are the indications which have been mentioned. And studies have shown just because you get more than one organism, it doesn't mean immunodeficiency. And these three organisms, RSV, influenza, metapneumonia, in addition to COVID, if they are positive, they are likely to be pathogens rather than non-pathogens. Let us move on to the CNS with the case number 4. This is a 1-year-old child who had fever, seizures, and encephalopathy. LP was done. And, often there is confusion. There is fear, particularly in a sick child with encephalopathy. How much volume you can take, how much volume you should collect if meningitis is suspected. And many small hospitals may not have need lab support immediately. So they have to collect, store, and transport. There are problems and confusion in doing the same. And in fact, there are microbiologists who feel that you should not be doing cultures for anybody and everybody who undergoes a lumbar puncture. So when you can safely defer cultures, and of course the CSF, BioFire, HSC, PCR, etc. I mean, there are so many questions related to that. Let me start with the clinicians. Dr. Shalini, how much volume should we collect if you do a lumbar puncture with suspected meningitis? Is there any guideline?
Yes, so the rough guideline, most of the literature that I went through said 1 ml each for cell count, chemical analysis, and 1 ml for culture. So 1 ml in each of these bottles.
Yeah. Even in newborn, we must remember we can collect up to 4 or 5 ml. Nothing will happen. Nothing will happen. No coning will occur. Okay, since the fontanelles are open, right? There is no such thing as guarded lumbar puncture. If you do a lumbar puncture, try to collect at least 4 to 5 ml. And 1 ml, you use it for immediate studies. The remaining should be stored for further studies whenever and wherever required. Please go ahead. Suppose you don't have a lab in your hospital. What should you do?
So ideally, like most biological samples, it should reach the lab as early as possible. CSF should not be refrigerated or kept in the fridge. It can be transported at room temperature itself.
Dr. Agnesh, do you send every CSF that you do, you collect for cultures, or you have any criteria for performing cultures?
When we are strongly suspecting a case of a pyogenic meningitis, and if we feel that the CSF is found to be positive because it is hazy, we definitely send it for the culture. And apart from that, we always collect a sample for the culture. Whether we utilize that sample or not, that is second thought. But at least first, we definitely collect in every case for the culture. Every case, whenever we are doing CSF.
It is said that you need not send culture if the cell count done properly is less than 10 per cubic millimeter. That's what is recommended, because otherwise it will unnecessarily result in increased workload for the microbiology. When do you ask for CSF BioFire, Dr. Agnesh?
In a sick child, definitely BioFire will give a good yield with regards to the organism which is responsible for the situation. But false negative also should be taken into the account. So, as in case of blood sputum and as in case of pneumonia panel, we can definitely go for BioFire with CSF when we are strongly suspecting organism and positive results.
Dr. Sulochana, what are the plus and minus of BioFire?
So it is an excellent sensitivity. With our experience, we have seen that it can pick up the HSV, PCR, and it is very fast. So again, as once we are confirmed that it is a viral meningitis, again, it helps us in the infection control, antibiotic stewardship. They cut down the thing. And also, if it picks up, because whenever there is a meningitis child is admitted, they give a sort of a shotgun therapy. They cover everything and they send it to the BioFire. When they isolate a pneumococci, when they get it, then they stop the acyclovir. This also we have seen that because it helps not only in stopping an antibiotic, it also helps in stopping an antiviral. So this is an excellent test and it should be used particularly when the child is sick with meningitis, it can be used.
And Dr. Camilla, in addition to, not including our own Japanese encephalitis, and I have read somewhere, but it may not be very good for cryptococcus. What are the limitations of CSF biofire in your opinion, Dr. Camilla?
Clearly, its cryptococcus is being described, especially in HIV patients. Biofire sometimes has missed it. So they always recommend that you should do a CRAG. That is a quick, an LFA test on the CSF, and that closes the book on cryptococcus. HSV is actually something that we need to be concerned about because it can be negative if the clinician is so astute, he diagnoses it immediately. If it's a mild illness, if they're low viral loads. In fact, if the clinical suspicion is high, acyclovir should definitely be given. Because in a study of, I think 40 pediatric cases, they found that just 74% of HSV were detected by PCR on the first day. And it rose to about 80% in 3 days. And so if it is negative, start the kid on acyclovir and repeat the HSV PCR within 3 to 7 days. Remember that we prefer to repeat the HSV PCR as a singleplex PCR, not as a multiplex. So we have in our hospital, when we get a biofire negative and it's real, the clinician is saying, no, I'm sure this is HSV. We repeat it 3 to 7 days later, day 1 of illness, 3 to 7 days later on a singleplex PCR. That means we're only doing HSV PCR alone, not multiplexing.
I think
sometimes we've been lucky.
That's a very, very important take-home message for all of us. Whenever you do multiplex PCR test, the sensitivity and specificity are likely to be lower than when you perform a specific PCR. Typical example is your HSV. Studies have shown the biofire can miss HSV PCR, whereas isolated single probe HSV PCR is unlikely to fail. Though there are many case reports where they have got cultures of HSV positivity in the absence of HSV PCR multiple times, and they have proven with brain biopsy, etc. So that's a very important take-home message. It includes, even RSV, respiratory biofire, even for corona. You do only COVID-19 PCR, that is likely to be more sensitive and specific than if you do it in biofire. Is that right, madam?
Actually, sir, COVID, we're really picking up a lot on biofire, but for HSV, no question. We may miss it because of multitasking.
The important message is if you have a clinical diagnosis of HSV PCR is negative, it is better not to discontinue acyclovir because it can be disastrous, because it can be positive later also. Okay. And some specific questions to our microbiology experts. Madam Camilla, when do you ask for 16S RNA to both Dr. Camilla and Dr. Sulochana? In fact, I know quite a few infectious physicians. Once they get a CSF or a pus from a brain abscess or pus from an osteomyelitis or arthritis, they ask for 16S RNA. When should a pediatrician ask for 16S RNA? It's an expensive test. Sometimes you don't know where to send. Your answers, please.
16S RNA is a great test because it's the RNA gene is universal in bacteria. And not only does it allow differentiation of the organisms at a genus level, but even you can speciate it at a species and subspecies level. So what is done usually that you do either a 16S RNA sequencing, and you do a PCR first, and then you sequence it either by Sanger or now we're doing it by MySeq. The applications really are quite few. They're essentially in neonatal sepsis where cultures are negative. So basically your culture is usually negative when you resort to a 16S RNA. The patient is serious, has a serious infection, it's warranting prolonged treatment. A focused therapy may mitigate the risks of adverse reactions, neonatal sepsis, even diagnosis of prosthetic joint infections in adults, we're finding it really useful, and culture negative endocarditis. So it is definitely a new armamentarium. It's too expensive currently to be routine practice. But when you're stuck, I think there may be a role soon. And as it becomes cheaper, I think it's easier to access it. Dr. Bala, the problem is when we throw out weird organisms that even I don't understand, and I have to look up to see what the hell this bug is. So my inadequacy is shown all the more with the 16S RR.
Dr. Sulochana, your comments.
It's all when the physician is struggling with the sepsis, but with the microbiologist, we are not able to identify or isolate anything. So all cultures are negative, but still the child is not improving. Then that's when we suggest, why don't you go for a 16S RNA? But again, one word of caution is the lab that performs this 16S rRNA. They have to be highly competent, because their negative values, certain times when the competency is not there, they might give weird organisms, that's also there, and also they may turn out to be false negatives also. So I would say evaluate the lab to which you send it, and that's my word of caution.
Okay, having listened to the two experts, I would share whatever little experience I have had with the 16S RNA. And I've also read about 16S RNA. There are few situations where 16S RNA could be of great help in early diagnosis. One of them could be weird diagnosis like brucellosis. Second is Kingella. So I have not come across. I believe Kingella is not going to be picked up routinely by culture unless you start doing 16S RNA from pus. You won't be picking up Kingella. And if necessarily, you will have to include a beta-lactam to cover Kingella in osteomyelitis and septic arthritis. So that could be useful. Second. Third, in difficult situations like infective endocarditis, brain abscess, 16S RNA could be of help. Of course, neonatal sepsis, when you have no clue in terms of cultures, 16S RNA could be of help. That's what I know about 16S RNA. But like most other tests, it will take for a few more years to have more clear data on 16S RNA, and the labs also become standardized with regard to performance of 16S RNA. My next question is, when do you ask...
Dr. Bala, can I just say one thing? There is a new panel out that's called the Joint Infection Panel that has Kingella on it. And it has a lot of very useful bugs. So a lot of our pediatricians are saying, our ID physicians are saying, I'm suspecting some organism that is on the JI panel, and we've used it in out of label situations and got good answers, So it gives, there's no worry, like Sulochana very carefully put it. You have to have good quality control. Without that, the 16S RNA is useless. So the good part of the BioFire is that it has the quality control is really up to speed. 3 times each PCR is repeated, and it's all inside the machine. There's no scope for doing, any external contamination. So that way, it's really up on. So whatever you do, even if you do 16S RNA, I would like it to be FDA approved, not an in-house one.
Okay. When should a pediatrician ask for anaerobic culture, and how should he do it? Your microbiologist should guide us.
Ours, we don't do the anaerobic, but the conditions, I can tell you, the clinical where the anaerobes are the highly suspected, like the abscesses, a brain abscess specifically, where we recommend the anaerobic cultures.
How does one collect the sample and send, Dr. Sulochana?
Specifically, the time and the mode of collection is the very, very important. It has to be inoculated very fast. And particularly, there are various levels of anaerobes. One is a very, very highly sensitive ones, but most of them can tolerate within probably half an hour, 1 hour, it has to be plated. Madam, your experience on this? I have a very limited experience on handling the anaerobic cultures.
Usually, most obligate anaerobes are dead even before, as soon as they're taken out. Within 15 minutes, they die. It's the facultative anaerobes that we try to grow. And usually, if there's any intra-abdominal, any GU infection, any brain abscess, like Sulochana said, brain abscess, it's it's really important to do an anaerobic culture because, you may miss it, you may see the organisms, they don't grow, and actually they're anaerobes. So any closed space or any site which is contaminated with normal flora should be done. Please don't do anaerobes on sputum or on urine or on stool. Those are really not advocated.
The point is, immediately after collection, it has to be plated. So the lab, there is no time for long transportation, because after plating, it has to be immediately placed in an anaerobic chamber. So there should be a team workup between the clinician who is collecting the sample and the microbiology lab. Immediate transport.
I think from what you both said, I think we should send somebody from the microbiology lab to the theater. When the surgeon opens up and gets a specimen, it must be immediately plated. Is that right?
No,
Best.
we have some transport media also.
Medium,
there's some Stewart media, there's Amy's media, even thioclaclate. You should put in, but the microbiologist has to get it fast and immediately open the jar and put it in.
Okay. Now let us move on to the GI tract and then to the lymph nodes. This is a child who had acute enterocolitis for over a week. He has received cefixime, he has received ceftriaxone, he has received azithromycin, he has received one other antibiotic. All stool cultures are negative. When somebody does a stool biofire, Clostridium difficile is positive. Dr. Shalini, how do you interpret this and how do you proceed?
So in this child, I would think of an antibiotic-associated diarrhea because there is history of exposure to multiple antibiotics, broad-spectrum antibiotics, and the clinical picture can fit in with a positive report for Clostridium difficile. It is one of the known causes for pseudomembranous colitis, as it used to be called. So I would interpret this as a positive, a true positive, rather.
Okay. Am I right, Dr. Shalini, if I say that amongst all the multiplex PCRs which are currently available, we have, respiratory, we have CNS, we have even for bone and joint infection, we have some bloodstream infections, etc. And we have one for GI. Which is the weakest one, Dr. Shalini?
Probably the stool, sir.
Probably stools.
Because it's so likely to have organisms.
What are the plus and minus of stool biofire? And as a pediatrician, when do you do stool culture? How do you collect, store, and transport sample for stool culture? Many a time mistakes happen.
So if I can answer it in the reverse order, first, how to collect the stool culture.
Dr. Yagnesh, when do you do stool culture in your practice?
Never. As a routine OPD practice, I don't do a stool culture ever.
Okay, inpatient, do you do stool biofire?
No, in ICU setup, it may be there, but not is our routine practice. Definitely not.
Okay, Shalini.
It's very rarely done, sir. It's not one of the common tests. I would much more be likely to do a blood biofire sepsis panel or a respiratory panel, CNS panels, rather than the stool. There are very few indications. One would be in a very difficult to treat diarrhea, severe disease, prolonged diarrhea where I'm not able to get a diagnosis. Or of course, again, in outbreaks, but of course we have not had those, fortunately. There would be some value in doing a stool biofire. Stool culture, because of its so many pitfalls in its interpretation, is a very less reliable test.
Okay. In fact, I do stool cultures quite often. I'll tell you why I do that. One, when I suspect cholera, I definitely ask for stool culture. Dr. Sulochana knows we don't depend on hanging drop anymore. It's not good. Not a good test. When you suspect cholera for some reason, and an older child coming with severe dehydration, unexplained watery diarrhea, yes, I do stool culture for epidemiologic purpose and for treatment. That's one. Second is dysentery. Inpatient, I do a stool culture because a growth of Shigella is not that difficult. If you do a good specimen collection, that should be easy. Even Salmonella can be picked up from the stool culture. Third is when I have a child with persistent diarrhea or a chronic diarrhea, I definitely do a stool culture to pick up vague organisms. Of course, stool cultures are useful only for picking up cholera Salmonella, and Shigella. These are the 3 bugs. Growth of E. coli doesn't mean anything, and we don't have facilities to do fast typing or toxin testing for E. coli to identify. In the West, they do, check for O1 so that they avoid antibiotics and prevent hemolytic uremic syndrome. My next question to Dr. Shalini: how do you collect, store, and transport sample for stool culture? Often there are a lot of mistakes. Not easy to get a stool culture done.
So stool has to be collected again directly into the bottle. That is another challenge logistically, because very often parents will try to scrape it off the diaper after the child has passed stool some time ago. So that sample is very, very likely to be contaminated, and it will not yield very reliable results. Has to be collected directly into that and transported to the lab within 2 hours. There are transport media available for stool culture in case there's going to be a delay. So in that case, the stool can be directly put in that medium and then shifted to the lab. For cholera specifically, alkaline peptone water is designed to be an excellent transport medium.
Do you recommend rectal swabs?
Not really, sir. No, I don't.
Should not be done. Rectal swab should not be used. They have very poor sensitivity and specificity. Okay. That your comments on stool biofire and culture, Dr. Sulochana.
So I have limited knowledge. Nobody uses. So I have my limited knowledge on the stool. Madam, I don't know. Anybody uses that?
Madam Camilla?
We use it. We use it basically for us oncology, our transplant patients. We use it to differentiate, when patients are having in bone marrow transplant. It's quite a useful test for such patients who get recurrent diarrhea, also to differentiate from GVHD. Okay. So, because there we don't know whether it is the diarrhea or it's GVHD. So, we using it in select situations for a really severe diarrhea. And we are getting organisms actually like Campylobacter, Yersinia, we've had on occasion, which we've not grown. So, we definitely don't recommend it in routine pediatric practice. Certainly not. But if it is a persistent diarrhea, if it is like in this case, I think one word of caution is that Clostridium difficile actually colonizes children, and should not be done for young children. The American Academy has actually said, please don't do it if the kid is really small. And but here, no question, the kid did receive a lot of antibiotics, so we would interpret it. But we need a word of caution because colonization with C. diff is an issue in children.
I think that's a very good message. You do cultures when you think you could be dealing with Shigella, Salmonella, or cholera. And you ask for stool PCR, multiplex PCR biofire when there is a complicated diarrhea or a persistent diarrhea or a diarrhea in an immunocompromised host, or when in a patient who's on immunosuppressive drugs, who's on steroid therapy, or when you don't know the cause for an infective diarrhea. Otherwise, stool biofire has got very little use in routine pediatric practice. For Clostridium difficile diagnosis, yes, it's a very useful test. Let us move on to the last case scenario, cervical adenitis. This is very, very common, very, very common. And of course, now we all know that FNAC has got very limited usefulness. If it doesn't give us a diagnosis, microbiological or pathological, we always end up doing a biopsy. Surgeons are surgeons. They will do a biopsy, and it is up to the physician to ensure that the right tests are done for the biopsy specimen. It's a very, very precious specimen. Okay. I'm going to ask Dr. Shalini, 6-year-old undergoes biopsy. Shalini and Dr. Yagnesh can answer this. A 6-year-old child, your patient, undergoes biopsy. The biopsy is done because of undiagnosed cervical adenitis for 3 weeks. What should be the right approach in collection, transport, and testing of the sample if infection is suspected? Dr. Yagnesh and Shalini. Dr. Yagnesh, please.
With regards to the sampling, the first whole of the lymph node should be removed, not the pieces of the lymph node or the part of the lymph node. That is the first message that I would like to convey. Once the whole lymph node has been removed, it should be put on the wet gauze piece and directly put into the sterile container. It should not be fixed on any other containers like formalin, fixed with the formalin or other procedures should not be done. So it should be immediately sent to the laboratory in the sterile container itself.
Okay.
Of course, it
What
can
about
be kept for 7 days. Yeah.
What
Yeah.
about the transport? In case you don't have a lab in your own hospital, what about the transport?
It can be refrigerated up to 7 days. Definitely, yes, no issue.
Okay. Okay. Any comments on sending specimens, Dr. Sulochana?
So one often mistake which we see certain times, it is sad to see, is they put it in the formalin. Where we have seen, because most of surgeons, they are so used to putting the tissue in the formalin, because most of the time they send it to histopath. So then we could not do any testing with this material. That is something which they have to word of caution. When it is for the microbiological any culture, they have to put it in a sterile saline. That is something they have to be word of caution.
Gene expert, many a time you may end up doing a biopsy on a Saturday. Gene expert is most of the time through ultra tests are done in government centers only on weekdays. Saturday, Sunday, what do you do?
So no problem, because MTB is a very robust organism. We have seen it sustains. It is just refrigerate the sample and send it. So no need to worry.
Keep it in sterile saline soap.
Sterile saline and soap cotton, and put it in the fridge. Send it across after 1 day, also 2 days also. That's why this is 7 days, particularly for MTB. Isolation is okay. It's a robust organism. It stays.
If you get pus, do you think it's worthwhile sending for 16S RNA also?
No.
No.
Dr. Camilla, please.
Too expensive.
Too expensive. Okay. Some open questions to our microbiology experts. MIC, minimum inhibitory concentration. We pediatricians, to be very honest, I'm sure many in the audience would also agree, we hardly understand this MIC business. How should we interpret it as clinicians, and how should we apply it for choice of antibiotics? And I'm at times surprised. Only in invasive pneumococcal disease, I find so many breakpoints, so many MIC differences. For otitis media, one for pneumonia, one for CNS alone, it is higher. Why this? Why does that decide the choice of antibiotics? Over to the two microbiology experts.
Sulochana, go ahead.
One thing I can answer first is the easiest one I'll pick up, the invasive pneumococcal disease. So the invasive pneumococcal disease, yes, it is definitely you need the MIC of the pneumococci that is isolated. First, if it is going to be a non-meningitis, but if it is an invasive pneumococcal disease, the action comes is when it is a susceptible, the concentration of the amoxicillin that you can use, the regular dose, whether you use a regular dose or the high dose, that's where the difference comes, because the beta-lactam antibiotics, it is a time-dependent killing of one, where you have to maintain the concentration of the antibiotic above the MIC level for that particular time, then it is effective. So let us take any non-meningitis invasive pneumococcal disease. When it is susceptible, you can use the regular dose. When it is in the resistant, still it will work, but you have to increase the concentration. The reason being, you are increasing the concentration of the beta-lactam antibiotic in the blood. So that is okay. But when it comes to meningitis, how much ever beta-lactam you are going to, there is a blood-brain barrier. That is why you need a very, very low MIC of 0.06. If you look at the penicillin. And also for the, that is when you look at for the non-meningeal, it is 2. But for meningeal, it is 0.06. The difference is coming not based on the sensitivity, but an additional factor of blood-brain barrier. So I will recommend definitely, if it is going to be a sensitive one, the regular ceftriaxone will work. But if it is going to be a resistant, definitely a vancomycin is the drug of choice. This is the point.
Dr. Sulochana, as somebody who has been following pneumococcus sensitivity over the last 15 years, what has been happening in KKCTH with regard to ceftriaxone resistance in meningeal isolates, penicillin resistance in non-meningeal isolates? Is it discouraging or encouraging?
It is dropping, but it is still good in the non-meningeal isolates. We can continue to use the beta-lactam ceftriaxone.
What about meningeal isolates? Do you think, based on your experience in KKCTH, do you think ceftriaxone is enough, or straight away you should start with ceftriaxone and vancomycin?
Only straight away ceftriaxone vancomycin.
Data in KKCTH, please.
Data on the KKCTH, we have seen a very high percentage of resistance, the penicillin-resistant pneumococci specifically in the CSF isolates. So highly recommend, when it is a meningitis, bacterial meningitis, we start on ceftriaxone with vancomycin straight away.
What about non-meningeal isolates?
It is a good sensitivity we are observing. Close to 85% to 90% are sensitive. That's what it is, varies, but it is dropping, that we are seeing. But it is still sensitive. You can go ahead and start with your ceftriaxone. This is what we recommend.
What about the MIC and UTI, Dr. Camila?
In UK?
UTI.
UTI, that's what the case that we discussed. That just sort of emphasized the point that, see, the MIC is the lowest concentration of the antibiotic that inhibits the pathogen. It is inversely related to the zone diameter. The larger the zone diameter, the lower the MIC. Now, there's something known as the breakpoint, which you just showed that slide. And this breakpoint is a concentration that categorizes the MIC as SIOR, or treatable from non-treatable. And one magic word is that MIC must be less than the clinical. So if you're achieving that in the urine, if your clinical we don't have breakpoints for urine, unfortunately. The BSAC has now come up with breakpoints for urine for the beta-lactams, and maybe we need to look at that. So if your MIC of the bug is less than the clinical breakpoint, you're going to be able to treat the infection. If it is more, you're not. And there's something else that's now doing the rounds. Just say you have a whole report showing all the antibiotics, some are S, some are R. Now, which is the first among equals? Which is the best antibiotic to use? And there's something known as the breakpoint to MIC quotient. So what we do is, we actually take the susceptible breakpoint and divide it by the MIC, and the higher the ratio, the better the antibiotic will be. So if you have a whole lot of S's and the clinician is worried, what should I give? You use it's called the breakpoint to MIC ratio, or the efficacy ratio, and there we find a lot of help to the clinicians if we can actually tell them that, this is the better antibiotic to give because its BMQ ratio is higher.
Okay. Let us ask both the microbiologists as well as both the clinicians. What do you think is the prevailing sensitivity pattern and enteric fever in India currently? What about ceftriaxone azithromycin resistance? I'm sorry for the spelling mistake. And to the clinicians, what is the role of cotrimoxazole, aztreonam, and meropenem? Yes,
the current sensitivity is that is highly sensitive. This is what is the latest study which shows quite a good number. It is the Salmonella typhus 2000, 100% sensitive to third generation cephalosporin, that is the ceftriaxone and the cefixime. And azithro, we have started seeing some resistance strains. But it is very rare, and it is very good sensitivity to ampicillin, chloramphenicol, and the cotrimoxazole. It's above 95% and very pathetic for the quinolones.
Okay, right. Dr. Shalini and Dr. Yagnesh, do you use cotrimoxazole, Dr. Yagnesh, for enteric fever? Have you used aztreonam or meropenem?
As a routine, ceftriaxone is the drug of choice, and almost, as the madam has already said, more than 90% is the sensitive. So the second choice will be azithromycin. And if both of them are not working, only then we need to go to the cotrimazole and azithromycin. In fact, a majority of our patients in enteric fever in our area, they are sensitive to ceftriaxone. Maybe sometimes I'd use azithromycin. Very rarely cotrimazole, and we need not go to the aztreonam and the meropenem for the enteric fever patients.
Dr. Camila, please.
I think aztreonam doesn't have much of a role because when enteric fever is resistant to the third generation cephalosporins, then it's resistance by means of CTX. I mean, especially in the newer ones that were reported in Gujarat, they found that there was a ESBL CTXM which will destroy aztreonam. The Gujarat episode was really scary because from where it came, they had almost several hundred cases of XDR, it was called H58 isolates, that had this plasmid that...
It was from Vadodara. Yeah, probably.
I know. And even Ahmedabad, sir. So,
yeah, some of the Ahmedabad cases.
So it was because it actually had this ESBL, so aztreonam wouldn't work. And it was cotramoxazole wouldn't work, and only meropenem was the drug of choice. And what is becoming worse, not in our country, praise God for that, is that the plasmid, this plasmid that is harboring resistance to ampicillin, cotramoxazole, and to chloramphenicol, it's actually moved into the chromosome. So once it moves into the chromosome, it gives space to the bacteria to take other plasmids, that is CTXM. So that is a dangerous sign, and that's happening in Pakistan. For us, so far, we are happy. We're not seeing much of third generation cephalosporin resistance. MICs are creeping up, but I'm not still concerned till we get this ghastly plasmid coming. The good part for us is that the plasmid usually comes at a fitness cost. For example, if I'm a bug, I don't want to carry a plasmid with me that may compromise my fitness. But once the fitness cost with a compensating mutation comes in, it's bad news for us.
Okay. The good news is that at least in most parts of India, ceftriaxone sensitivity continues to remain nearly 100%. Good news. And azithromycin, MIC might be going up, resistance is not reported in a big way. Of course, in Gujarat and other centers, they have reported this ESBL, in which aztreonam won't work. Cotramoxazole is a good choice for if you have sensitivity reports, it's a cheap man's alternative. And there have been reports of meropenem failure also. But if there is an ESBL producing multi-drug resistant, extremely drug resistant typhoid, you have no choice other than to use meropenem. Let us move on to the final question. Before that, I'm happy to share one of our own publications from our hospital. Recently, only last week, this paper was accepted. Dr. Sara, our virologist, who carried out this study, she could publish it with the teamwork. We analyzed the PCR for diagnosis of scrub typhus. In fact, I'm not giving all the details. We reported in the Zoonosis Journal recently that the real-time PCR had very good specificity in discriminating scrub typhus from enteric fever. That's the most common differential diagnosis, with or without a shot. And we reported, I'm not going to the details, we reported that the PCR for scrub typhus has got a good sensitivity and specificity. That made me ask a question to the two microbiologists and the two clinicians. I'll start with the Agnesh first. Do you do fever panel with multiplex PCR now? Agnesh, there are quite a few panels which are available. They cost anywhere between 2,500 to 5,000. Dengue, chikungunya, leptospirosis, typhoid, leptospirosis.
Rickettsia.
Rickettsia, yeah. 5 in 1.
No, we do not usually go for the panel for the fever. In fact, depending upon the presentation and other clinical signs, we try to pinpoint to the one particular disease and then first rule out that disease. But I have never gone for the fever panel multiplex.
Shalini.
It does have a role in the workup of a PUO. So when there is a fever without a focus, no rash, no telltale signs, there may be, and there's a history of, say, travel, I'm suspecting a zoonotic infection, it may have a role, particularly because if I want to start or stop doxycycline to avoid unnecessary escalation of antibiotics, it does have a role.
So fever means 8 days fever. You admit you will ask for a fever panel. Is it? Do you ask
No,
for it?
no, sir. In the absence of other localizing signs, when I'm not able to, cultures have been negative consistently.
Okay. Let me ask the two microbiologists. Madam,
We are using it, but after we've done our RDT is negative, RDT is done, our dengue serology is done, our chikungunya serology is done. We're finding good results with leptospira. We're finding good results with typhoid and rickettsia, the spotted fever, not so much scrub, which is why we have, exactly like Dr. Bala showed, we have a singleplex PCR for scrub. So I think it has a role, but once the easy tests are excluded. But again, it has to be done early in the infection, within the by 5 to 6 days.
Dr. Slochana.
So in our hospital, we don't do it. We are very specific. Clinically, come to a differential diagnosis, and then they ask very specific. We don't do it.
Yeah, I think it's a good and bad test, I would say. Good in the sense it can be very, very useful in picking up chikungunya, probably leptospirosis, dengue, right? And I believe typhoid so far has been very disappointing. Dr. Milam and Sulochana might know more. For various ununderstood reasons, typhoid has been a disappointment in this multiplex PCR. Of course, dengue is coming up in a big way. There is enough data that dengue PCR could be more sensitive than even the dengue NS1 if done properly. And rickettsial, yes, it could be useful. Leptospira, yes, it could be useful. As I said in HSV, very similar to multiplex PCR elsewhere, individual PCRs might have more sensitivity and specificity than multiplex. Technology is emerging. I think we need unlike BioFire, which has been approved by FDA, Dr. Kamila, is there any FDA-approved kit for fever panel?
It is CE approved kits, but not FDA approved, because FDA doesn't have these fever panels. They don't see. US doesn't care about us.
Yeah. I think we must come out with the TrueNat machines available. We must come out with our own.
They are coming up with a fever panel.
Yes. I think that is going to be the future. And we come to the end of the session, and the take-home messages would be: first, as clinicians, we must have a clear assessment of the patient's clinical details before asking for any laboratory tests, particularly microbiology tests, which are very, very useful in infectious diseases. First step is a good clinical diagnosis. Second step is asking for the right test at the right time for the right patient. And the next step is the correct collection of the sample, correct transport wherever possible immediately to the best lab available, or for some reasons it is delayed, to store properly. And the last step, and the most crucial step, I would say, after getting the report, if you can't understand or decipher, or even if you understand, if you have the slightest doubt, call your microbiology friend to discuss the several points given in the report, which includes MIC, ESBL, etc., etc. Discuss with her or him before we decide the correct treatment. And as always, we should be treating the patient and not the lab reports. With this, we come to the end of this session. And I'm sure there will be a lot of questions from the audience and also from the experts who are viewing this. Let me go through the chat box and find out if there are any questions.
Can you please stop sharing?
Yeah, 1 minute. I just stop sharing. Just a minute.
I have also put some questions from YouTube because there it has been relayed.
Only thing I'll have to see the questions. 1 minute.
Yes, sir. Yes, sir.
1 minute.
While Dr. Bala comes out with his YouTube questions, can I ask a couple of questions and comments, please?
Please go ahead, Vijay. Please go ahead.
Yeah. First of all, I mean, I totally agree with all the experts that a test is as good as its pre-test probability. So that one has to take into account. Talking about this fever panel, as Dr. Kamila very correctly said, I mean, once you exhaust your cheap and easily available and reasonably sensitive test, does it make sense to use this PCRs? But simple PCRs would be much more cost effective than your multiplex in such situations. And the only apprehension is most of these are available. Like, say, Dr. Bala, you talked about your rickettsia PCR. These are all open platform PCRs. And given the sensitivity of a molecular test, PCR test, how do you ensure a strict quality control and false positivity arising out of contamination? DNA is multiplied million-fold in a thermal cycler. So, what are your comments, Dr. Kamila, on this?
Dr. Vijay, that's where the closed cartridges really score. Things like Gene Expert, the BioFire, everything is closed. The amplicons are not exposed at all outside. You can't get them out. So that's really a good part of these open and I think once the microbiologists themselves have to be very cautious when they start getting 2 or 3 positive patients, and you have to do regular checks. Actually, even surprising, even though I said Gene Expert, sometimes we find even Gene Expert can be false positive. So in our lab, we have a protocol that we clean the probes every 4 days with bleach. It's just done as a routine because we just don't want to take a chance because that probe keeps going inside, when it's inoculating the first time. So it's one of the double-edged swords that we have to live with. And quality control for molecular tests is of paramount importance because you're going to lead the clinician up a tree if you don't have good practices in your lab. I think NABL is becoming stricter and stricter. That's one good part. And we just have to trust that the labs are doing everything properly, in a good, and which is why I like these systems that are, manufactured where you can't compromise on the controls. Because the control is taking a test. When you do positive control, negative control, the calibrators, it's taking 5 tests. I mean, when I do an HSV PCR, I'm using 5 reagents for one test, control reagents. So there's a temptation to sort of cut out on controls if you're doing these in-house PCR. That's unfortunately a sad truth.
Yeah. And most of these fever panels are at this point in time open platform test, right? Yeah. None of them is available as a closed test.
Fast track was, but I think now they're mainly local.
Yeah. My question
Dr.
to
Vijay,
talked about. 1
minute. Dr. Vijay,
yeah.
Whenever you talk about any platform, particularly related to respiratory secretions, there's lot of confusion with regard to the interpretation reports for various reasons. In fact, somebody has asked in the chat box, adenovirus found in throat swab tech, can it be bystander? Yes, it can be. It can be. Even RSV can be there. Test can be, PCR can be positive for about 4 to 6 weeks. You can't predict. You can't predict. Say 100% RSV PCR is positive. It is only RSV. So it can remain for a long time. And all these platforms are unfortunately limited in usefulness because there is no quantitative test. Nobody has standardized the measurement in terms of quantity and come out this much quantity means bystander, this much quantity means true disease. That is not available as yet. Technology is emerging. Yeah. Please go ahead,
But
Dr.
again, BioFire is supposed to be a semi-quantitative kind of a platform.
It's only semi,
However,
not fully quantitative.
I understand, but however closed and standardized the platform may be, the problem arises when a wrong sample is used. For example, people are trying to corroborate, nasopharyngeal swab with a probable pathogen causing pneumonia. Where the fallacy lies, it's an incorrect approach to definitely a BAL would definitely be much better than a nasopharyngeal swab. Coming to second question to Dr. Sulochana, she talked about azithromycin resistance in salmonella. What is your definition of in vitro azithromycin resistance? Have you tried to correlate it with clinical failure? Does it correlate well?
We have never seen at our hospital an azithromycin resistant strain. We are a part of the study which we did as a multicentric study, where some of the isolates were azithromycin resistance. It was found in CMC Vellore. But we have not come across not even a single strain which was azithromycin resistant.
But that CMC Vellore had clinical failure also?
I do not know about that particular case. This is what the antibiotic pattern that they told. We did not get, because it was from a different center, they did not share the clinical details.
Because I believe it has always been a problem to corroborate in vitro azithromycin resistance with clinical failure because of its ability to achieve very high concentration intracellularly.
Yeah.
And secondly, you talked about CSF needs to be transported immediately, and it's a big handicap if the laboratory is not in-house or not nearby. I remember once Dr. Camilla mentioning that you collect the sample in Bactec bottle. That solves the problem. You just collect it in Bactec bottle and send it across. You can store it overnight at room temperature and send it next day. Am I right, Dr. Camilla?
Yeah. We always inoculate it into Bactec. We also send for routine, but we find Bactec is already started the incubation at room temperature, never put it in fridge after inoculation.
I think this message we should send to all pediatricians, that this is a way you can circumvent the problem of non-availability of lab in the near vicinity, or delay in transportation can be taken care of by this kind of a system. And final question is,
Dr. Vijay, it has to be a pediatric bottle. It can't be a normal Bactec.
Yeah. And final question is, urine. Dr. Camilla, you get urine for samples for culture. Do you always perform urine routine and look for pyuria? And do you not go ahead with performing culture if there are no pus cells in urine?
We always do it. It's part of our workup for urine culture, and we write on the report that please note there were no pus cells found, even if we do culture it, because by the time it's done, in the lab, it's not that is done first. We are quickly culturing up everything, and the urine routine is done and kept. But we write on the thing, please interpret clinically as there were no pus cells, or there were just 1 to 2 pus cells.
But what is your interpretation? An appropriately collected, stored and transported sample, if it shows no pus cells but culture flags positive, do you define this as UTI? Do you call it UTI?
No, the issue here is that what was the frequency? Sometimes children, see, the whole concept of 10⁵ significant bacteriuria came in asymptomatic pregnant women, but it's on the premise that the urine has to be in the bladder for at least 4 to 6 hours. Now, which little baby is going to keep the urine in the bladder for 4 to 6? So if it is passing frequently, sometimes, there may be colony count also may not be reached. But if there is nitrite positive, and if you're sure of, another point, Dr. Bala, I wanted to make with the urine routine, not culture, urine routine, if you have to do it fast, and the preservative that you use, something known as toluene. Toluene comes on the surface and it doesn't allow any degradation of cells. That urine can't be used for culture, but toluene is a very good preservative for the urine routine if you're anticipating delay. I just remembered that. So difficult, Dr. Vijay, really difficult for us to make a judgment call, but we just say it's your job.
So nitrite to nitrite, I can understand, no stagnation, but pus cells would also disappear if there is frequency of urine.
See, the thing is that inflammation should be there. So I feel there must be some inflammation in a UTI.
Dr. Camilla, I remember the AAP guidelines on UTI in 2000 or 2004 mentioning that 3% of UTIs may not have significant pyuria. 3%. 3%. If you remember the figures, 3%. 1. 2. You must remember that in addition to the gold standard of culture, one earlier gold standard has been the gram stain of a centrifuge specimen of urine. If you find bacteria, first published reports in adults have shown that it is as good as a urine culture positive. Correct me if I'm wrong, Dr. Kabila.
Provided
Absolutely.
it is done on freshly watered sample, immediately avoiding.
Whether it is, see, of course, that goes without saying. That goes without saying. In fact,
No, but that's practically impossible. Practically impossible.
Ideal thing, you collect a urine means immediately run to the microbiology department. You collect a CSF means run to the microbiology department. You collect a blood culture, run to the microbiology. That should be the motto. I think do your test as fast as possible without wasting time. That's
but especially bacteria smear. Looking at the doubling type of this gram-negative uropathogens, if you allow the urine to stand for say 30 minutes and do bacteria smear and find bacteria, would you
30
really
minutes is fine.
call it?
Vijay, 30 minutes is fine. Okay. You just make a smear of an uncentrifuged, Dr. Bala. It's an uncentrifuged urine. If you find even one bug, it correlates to 10 raised to 5.
Yeah, but even centrifuge, if you find gram stain multiple organisms, specimen collection has been proper. It is as good as a culture positivity. As good as a culture positive. Of course, it's not 100%, but it gives you a clue that there is definite infection. Because sometimes, the problem comes because, you have a child with UTI, pyelonephritis, you admit the child, give IV fluids, correct the dehydration, the child is voiding urine frequently, and the child may have also a bowel bladder dysfunction, frequently urinating. You may not get enough bacteria in the sample. You may not get enough WBCs also in the sample. You have to go only by the culture.
Agreed. And one final question to Dr. Bala.
Yeah.
One fourth of pneumonias have dual pathogens. Co and super added bacterial infections are known in many viral pathogens. Given the fact that the mucociliary clearance goes for a toss, defenses go for a toss. So how do you decide on implementing that ASP in a pneumonia child where, say for instance, that metapneumovirus that you showed, it had a clear segmental collapse consolidation. So what do you base your decision on? Is it that all viruses are single pathogens and there is never a co-infection or superadded infection with bacteria?
I can't give an answer with 100% sensitivity and specificity. Okay, but let me tell you, ultimately, the decision on antibiotics, unfortunately, even with the advent of BioFire and all these sophisticated tests, procalcitonin, CRP, counts, band neutrophil ratio, etc., unfortunately, continues to be clinical. Okay, aided by radiological findings. But if you look at literature, the differences between clinical differences between viral and bacterial pneumonia, they have only one clinical sign which has very good sensitivity and specificity in ruling out a bacterial pneumonia. That is presence of wheeze. All other things can be present either in viral pneumonia or in bacterial pneumonia. It is only a holistic clinical judgment. And it can never be perfect. To quote literature, you take up Mycoplasma pneumonia. We always feel that we don't diagnose, it's underdiagnosed. But I feel it is actually overdiagnosed. There was a very interesting study published in Journal of Pediatrics 2 decades back. Some crazy fellow did PCR from the NPA of normal school children for Mycoplasma. And he also did it for children with pneumonia. And he reported children in the school had higher positivity of PCR for Mycoplasma than children with pneumonia. So that's where it is. The problem is we don't have a gold standard set of tests to differentiate viral and bacterial pneumonia. We continue to rely on our clinical judgments, aided by tests including complete blood count, and in some cases even ESR or CRP, and or procalcitonin and biofire. And we all know that less than 10% of pneumonias only have got sputum positivity. And unlike adults, in whom you can make a diagnosis of pneumococcal pneumonia with urine antigen test, you can't do that in children because children are nasopharyngeal carriers. They may have a false positive urinary antigen test. So these are all the limitations. We continue to depend only on our holistic clinical judgment, unfortunately.
Sir, can you take the questions very rapidly? There are many questions, sir. Can you take the rapidly, or shall I ask you from the chat box?
Yeah.
The cost of 16S RNA, madam? Somebody has asked.
I think it's about 15,000.
15,000. Okay. And Dr. Baldev Prajapati said stool culture for cholera in case of HIV and PID. Yes. Okay. Then any preferences over rotavirus antigen versus stool culture in suspected rota patients? Rotaviral diarrhea.
Rota is useful to know because you can cohort your patients. You know,
The
it's
rota card test for antigen, it costs only 500 rupees. It's quite cost effective. It's got good specificity and I mean, 2 card tests. One is rota card test, and even adenovirus, there's a card test available, which costs only 500 rupees. It's quite useful, quite useful, quite useful. You need not do biofire, which is expensive. If you want to diagnose rotaviral diarrhea, yes, rota card test could be of help, but more specific and sensitive will be biofire.
Okay. Sir, any difference in biofire? Because we are mentioning the brand, because it is a commercial brand available biofire for multiplex PCR. But now there are many other laboratories having different multiplex PCRs. So is there anything very to choose between these two? Any standardization they are lacking other or any other test at par with biofire? Madam, cameraman.
See, biofire is a commercial one. Today, another one, Kaya Stat is coming up. That is from Kayagen. That is another new commercial one. The other ones are Indian companies are now coming up with multiplex PCR as kits. Whatever you do, a kit is possibly more standardized than an in-house multiplex PCR.
So these the standard things to be used, right?
Yeah. Try and use something that has some quality assurance in place.
Okay. Then what antibiotic for community acquired cholera, sir?
Doxycycline or azithromycin. Most of the cholera strains in India are resistant to cotrimoxazole, and many are resistant to quinolones.
Okay. What rate of ceftriaxone resistance to salmonella across the country? I think this was asked before the discussion started. Then Dr. Baldev sir is saying that he's there very much there in the screen. In last 4 years in my institution, we had almost 500 blood culture positive enteric fever, all sensitive to ceftriaxone and cefixime. Same is with even us in our practice, prior practice also.
Yes, that's our experience in KKCTH also. We have not had. And Dr. Baldev said for CB-NAT, it should be in normal saline. Yes, sir. Saline specimens. Agreed.
And he said fever panel not in routine practice. Okay. Then role of rapid card test for lepto scrub, Dr. Nalini is asking.
We are not too happy with that, Dr. Chetan. We find that for lepto, the PCR is really good. The first 5 days, 7 days.
Okay. Dr. Palani has commented urine routine, no pus cells and culture positive can be applied in newborns.
Yeah. It can occur even in older children. That's what I said. 3% of UTIs may not have pyuria, but may have urinary infection. It is well documented in literature.
So for in our hospital, the urine routine and urine culture, we don't combine. I mean, it goes to 2 different labs. So what happens for, when we get a urine sample in microbiology, we do not know whether urine routine has been done. So default, when a physician wants, they order a urine culture, we get it done. And another caution, if it is a single organism, even if the colony count is low, we retain the plate and inform the physician. We retain it for 24 hours. Because as sir told, when there is a dilution of the urine is happening because of IV fluids, probably the colony count will be low, but still the physician will be suspecting the UTI. So we retain the plate, and only when we don't get a call from the physician, we discard even if there is a low count. If it is a single column, single time.
Baldev sir has written, in the given case of pneumonia with X-ray showing opacity with multiplex reported as metapneumo, I think discontinuation of ceftriaxone is not a wise step.
That's what I said. There is a holistic assessment. Counts are normal. Fever was not there. Wheeze was there. Hypoxia was there. Cultures were negative. By the time cultures or blood cultures are also done negative, it was a holistic clinical judgment. We not starting, I would agree, but continuing even after 2 days, I'm afraid we are right, and the child is also well on follow-up.
Dr. Sharad Balaji has commented that TrueNet for microbacterial tuberculosis has many false positives in our cohort. So TrueNet is not having so much of false positives. So please prefer CBNet.
What is the question?
Dr. Sharad Balaji has commented that TrueNet so much of false positive. And TrueNet for Mycobacterium tuberculosis has many false positive in our cohort. So that's what he insists for the CBNet.
Dr. Camila, please. I have no experience in this. Dr. Camila, please.
See, we are doing CBNet in our hospital. We are doing ultra. Now, with ultra also, there are some issues when you get trace positive, and that becomes a huge problem. So with ultra, with trace, we are very particular how to report it. But low load, medium load, and high load are all accurate. If your TrueNat is giving you false positive, you need to service the machine. You need to call the TrueNat people in, and you need to change all your buffers. We found that is a very important cause of giving false positive.
Okay, Dr. Yogesh Chaudhary is asking how much volume of sputum is required for culture and sensitivity and gene expert, and how much time is required to transport this sample for gene expert and culture for AFB.
Gene expert for sputum culture, we just need about 1 to 2 ml, and gene expert is about 0.5, not much. So 3 ml should be fine, and as soon as possible. But gene expert we can do it. It's not a great hurry for gene expert. Just keep it in the.
Dr. Yevle sir has written UTI is most under and over or misdiagnosed condition. And Baldev sir has commented without PIDA, culture positive UTI is also known. So that's we end all the discussion and questions we have answered. And so I would like to have a word from Dr. Baldeva. He's been there and commenting. If he can come up.
Yes, Baldevji.
No, I think no comment. The only thing that the best opportunity to learn all the things and learned a lot. Thank you very much.
Dr.
Chetan, I have a suggestion.
Yes, sir.
Change the name to Until 11 from Super 11.
Or make it Super 11 until 11.
Dr. Shyam is also there.
I wanted to ask one question from Dr. Kamila. And the question is, Dr. Kamila, what we have been doing for last 3-4 samples of pleural effusion. We take the sample and send it as BAL. And we are growing streptococcus. The streptococcus comes positive. So done this jugaad whenever cultures are negative, blood culture is negative, everything is negative. We have done this with BioFire. And 3 samples have come positive. It is not a validated test. So it always becomes a problem to de-escalate. But I have been de-escalating. What is your view on that?
You are using, I didn't get what are you doing with your pleural effusion?
They are sending it for BioFire. They are sending it for BioFire.
So you're using it as an off-label. It's okay, do it.
If
it's giving, okay. See, the issue with these BioFires is that they are very specific to the bug. They have standardized it for that particular metrics, that is sputum or whatever. But they will tell you what the bug is. The bug they'll not go wrong.
I'm getting the bugs, all the 3 times Streptococcus pneumoniae, but the problem is not validated. So there's always a question.
No, we are also quietly doing that when we are really stuck. But we don't, we'll phone up the clinician and say that, that we are getting this. But
the first time, what was happening, the microbiologists were not accepting. So I sent it as BAL sample.
No, we understand. See, because it's very specific for the bug. Remember that. So if
Dr.
you're
Sham,
getting strep pneumonia, it's not a false positive.
Unlikely to be contaminated.
Yeah.
Dr. Sham, you can do Binax test, which costs only 500 rupees. Why do you want to waste money?
I'll do that now also, sir.
No, Binax pleural.
I know. Binax on pleural fluid.
500 rupees, pleural fluid, pericardial fluid.
But again, I think we have done on CSF, but we have not done on pleural fluid.
You can do, we do it. We do it.
Can be done.
Can be done.
Can be done. Should be done, in fact.
All fluids, even urine, everything.
Yeah.
Say urine, it's not recommended for kids, but that can be.
500 rupees only.
Thank you. Very well done, and a very educative talk we had.
So we'd like to have comments from our own chairperson, PIDA, who has been, instrumental in facilitating all this thing, the webinar. Dr. Darur, sir. Sir, unmute.
I hope it went the way he wanted. He was very particular that it should be a clinical discussion. I was even worried.
Darur, sir, you just unmute. Yes, sir.
The days have gone where we used to have a side lab. I used to draw the samples and try to gram stain by the side of my ward itself. This has led to the misconception of negativity of gram stain. People are forgetting gram stain. Second thing is the sample collection. All these days, people discuss about the urine, but this is the first time I heard that 6-hour stay is a must, which is the basic principle for negative reports. We are giving samples within 3 hours, 2 hours of stay in the bladder. So, which is a defective sample that has been submitted for probe. And rest of the things, they are very, very crystal clear, and all the experts have participated. I am very happy, and congratulations to Dr. Bala for starting this program. Thank you.
So I think so. So, madam, the early morning sample is better in that sense. First urine which has been passed. Okay.
Because it's stored in the bladder for 6 hours.
Correct.
Again, Dr. Chetan, that first morning urine is based on data from women. Colony counts 10 to the power of 5 has come from women. I think in pediatrics, it's not necessary to have first morning specimen at all, except in adolescent girls. Any time which we should be able to get it, if it is true UTI. I think that's adult. The early morning specimen, first specimen, etc. I don't think we should extrapolate it to pediatrics and make it more difficult for the parents, for the child, and for the clinician.
Sir, one more submission.
Yes, sir.
Cholera, you said the rectal swab is of not that much significant. But, sir, I have treated 6,000 patients in fever hospital, which has got a GA ward. Cholera from entire Hyderabad comes there. It is the rectal swab that is highly positive if you examine and grow. So if there is no collection of stool, you have the facility of doing rectal swab that gives you almost all equal report. That is our experience from the Institute of Tropical Diseases, Hyderabad.
Okay.
So thank you so much, all the panelists and the moderator, Dr. Bala sir, Dr. Kamila ma'am, Dr. Sulochana ma'am, Dr. Yagnesh bhai, and Dr. Shalin Sharma for the wonderful discussion. And I would like to thank all the dignitaries who have been there all throughout. I can see at least Dr. Kea, Dr. Palani, Dr. Rashna, Dr. Jayan Joshi, all are there. And there are many on the YouTube also, Dr. Jalil. So thank you so much, all of you, for this wonderful discussion. Hope to continue the same. Next is, again, it is the last Thursday of next month. So we'll be announcing the topic and the faculties in due course of time. Thank you so much and good night, everyone.
Right.
Thank you.
Thank you.
Good night.
Good night.